Slides, shading. Slides from the main. So good afternoon, everyone. So welcome to Televersity. So today I'm talking about US ERCP interface in hepatobiliary system, pancreatic biliary systems. Coming to both the modalities, that is EUS and ERCP. EUS is endoscopic ultrasound, and ERCP is endoscopic retrograde cholangiopantography. They are both distinct, but they have got some complementary role in each other. So it is used in the diagnosis and management of pancreaticobiliary diseases. EUS is primarily once it is introduced, like when it was introduced, it was mainly of a diagnostic tool and staging tool. It was started with like that, and ERCP was primary. It was a therapeutic intervention method. ERCP it was started like in the late 1960s. So exclusively it was had a therapeutic role for a long time. But recently with ancillary techniques like intraductal ultrasound, cholangioscopy, probe-based confocal laser endomicroscopy, it has got some diagnostic role. With this intraductal ultrasound, we can see the thickening of the bile duct, and with the colonoscope we can take targeted biopsies, and the confocal laser endomicroscopy, it has got a magnified images of the cellular structures. So we have got this, we can target the tissue using these methods, which helps in the diagnosis of the tumors, but it has got some limitations. So ESCP has got some limitations. One is faint cannulations. In normal anatomy, bile duct cannulation can be achieved in 90% of the patients, but in 10% of the patient, it will be difficult to achieve those. In those methods, in those times, we need other techniques where we can achieve the cannulation. Other limitation will be altered anatomy by previous surgeries, especially one by reconstructions. In those patients, it will be difficult to achieve normal ERCP. What are the indications for ERCP? So in biliary diseases, it is used for CBD stones, benign biliary strictures, where there was inflammation or congenital strictures, postoperative strictures, malignant, so cholangiocarcinoma, ampullary lesions, so any infiltration by neoplastic diseases. In those patients, we can use ERCP as a modality to drain the bile duct, and also in bile leak, and also sphincter of Oddi dysfunction. In pancreatic diseases, can be used in recurrent idiopathic acute pancreatitis, chronic pancreatitis with strictures, if there is a pancreatic duct leak, and also in pancreatic collections like pseudocyst, any ductal disruption, we can use ERCP as a therapeutic modality. US. Coming to US was first. It was started in the early 80s. So it was first developed as a modality for diagnosis. So with linear echo endoscope, so what you can see, the upper one, that's a linear echo endoscope, and down is a radial endoscope. So radial endoscope, it has got only diagnostic ability, whereas linear with the therapeutic channel, we can do therapeutic interventions. So within the last 10 to 15 years, US has got it has transferred from a diagnostic modality to a therapeutic modality. So EUS indications, so GI tract cancer staging for diagnosis, then tissue sampling of lesions, so adjacent to the GI tract, and evaluation of abnormalities of pancreatic and biliary tree, exceptionally masses, dilatation, or any stones. As a therapeutic indications, it is used for drainage of gallbladder, US guided anastomosis like GJ, US guided photodynamic therapy, US guided brachytherapy, US guided fine needle interventions into the tumors like injecting chemotherapy or anti-tumor agents. We can use this monitoring patients like in a pancreatic nephritis. We can use US guided interventions. US guided any vascular intervention we can do. So like application of coil or sclerosing agent, especially in varicose status like fundal varices. So, is there any role for both as a combined procedure? So, if it is there, so when we can use it? So, what are the benefits? And if so, if there is any complications with that? So, with this combined approach, there is a concept called EURCP concept. That is endoscopic ultrasound retropancreatography, where we use both these modalities like EUS and ERCPs. So this combined approach, it is used like once there is any when one modality fails. US often guides decision making for subsequent ERCPs, or US can be used as a salvage method when ERCP fails. What are the benefits of this? So it is a single sedation. We can do both the procedures, reduce complication, and also reducing the hospital stay and the cost to the patients. What are the indications? So, both the modalities can be used in indeterminate biliary strictures. So, when the diagnosis is not known, EUS helps to provide a tissue diagnosis, and ERCP can be used for a draining procedure. So, once there is a biliary obstruction. So, second indication will be difficult biliary access. So, in a patient with altered anatomy where ERCP fails, we can use a US guided access method. So, and we can complete the ERCP. Third is pancreatic diseases like patient with pancreatic malignancy. US helps in diagnosis, and if there's obstruction, we can use ERCP as modality for to drain the bile duct. And patients in the management of pain, so US we can use for the celiac block. So, what are the various how we can use both the methods? So, in the first stage, it is like EUS indicates ERCP that in this EUS has got only a diagnostic role and ERCP has got a therapeutic role. Second stage will be EUS complements ERCPs. So, both has got equal role. Third one is EUS facilitate ERCPs. In this, once the ERCP fails by normal method, EUS helps to do like complete the ERCP. Fourth will be EUS replaces ERCP. Once ERCP cannot be done, then EUS can be used as a modality. So with these, each stage, the risk of adverse events are more. Like in the diagnostic EUS followed by ERCP, that has got lesser risk compared to the stage 4 where EUS is used as a like substitute for ERCP. And also the level of competency to perform the both the modalities, it is more when you reach the fourth stage. First one, it's like EUS indicates ERCPs. So in this, EUS must be done first, and it determines whether ERCP is subsequently required or not. So indication is once like indeterminate risk of cholelocolitis. Once in a patient who has got a symptomatic CBD stone with a dilated bile duct and normal LFT, or normal duct with abnormal LFT. In these cases, they will require a second modality to confirm whether the stone is there or not. Either EUS or MRCP should be done before ERCP to confirm the presence of CBD stone. So there are some studies. So there is a meta-analysis like diagnostic accuracy of EUS was compared with MRCP in diagnosing CBD stones. This meta-analysis showed the sensitivity and specificity of EUS was comparable with MRCP, and it was more like beneficial in patients with the distal CBD stones where EUS can pick better than MRCP. Second, there was one more systematic review where they compared EUS versus ERCP for suspected CBD stones. In this, this showed like endoscopic ultrasound before ERCP and direct ERCP. This review showed performing EUS beforehand avoided ERCP in around 67% of the patients. So by proving there is no CBD stone. And also, this review article showed significant reduction in adverse events in patients with previous EUS when compared with the directly patient going to ERCP. There was the adverse event was around 6.6% versus 19%. And also, post ERCP pancreatitis also was lesser in patient who underwent EUS before ERCP. So this is a EUS image. This is in the duodenal bulb. So in this duodenal bulb, you can see two anechoic structures. One is the proximal to the probe, and one is distal to the probe. One is proximal, is a CBD. Distal is a portal vein. So in this again anechoic structure, you can find an echogenic foci with the acoustic shadow. This is a CBD stone. This is another example, same. So this is the CBD anechoic structure with echogenic foci, where we can see acoustic shadow. This is a CBD stone. Once you confirm this in a suspected CBD, you can go ahead with ERCP. If there is no stones, we can avoid ERCP. Second, EUS complements ERCPs. So in this, EUS and ERCP are indicated and they complement each other. Each has got its own role. Indications: so pancreatic biliary neoplasm with obstructive jaundice, any pancreatic collections due to ductal pathology, secondary to acute or chronic pancreatitis. So CA pancreas with jaundice. So in these conditions, both have got a role. Like first one, so pancreatobiliary neoplasm with obstructive jaundice. So, for example, in a patient with pancreatic head mass causing biliary obstruction, bilirubin more than 20, in this patient, we need a diagnosis or also intervention to reduce the obstruction. So, first we can do is EUS guided tissue biopsy to confirm the diagnosis, and then followed by ERCP to ERCP and stenting to relieve the obstruction. So, this is a head mass, and this is an iconic for in the D1. So this is an iconic structure, that is a CBD, and this is a pancreatic head where there's a heterogoic mass. So with the complete obstruction of the CBD. So we can take a biopsy. This is the needle. We can take a biopsy, and then followed by ERCP to relieve the biliary obstruction. Other thing is, second is pancreatic collections associated with the ductal disruption, second to acute or chronic pancreatitis. So once there is any ductal disruption, this is an ERCP showing the pancreatic cannulation. This is the pancreatic duct with the contrast leak. That is a ductal disruption. In these patients, we can put a PD stent to bridge the disruption. And also, if the collection is large, we can go ahead with a EUS guided drainage procedure. So either it can be a plastic stent or a metal stent. So this is a lamps which can be used to drain the pancreatic collection. Third will be a CA pancreas with obstruction. So EUS can be used for diagnosing, and also it has got some therapeutic role also. EUS it can be used in like giving a celiac block if the patient has got advanced cancer with severe pain. So we can reduce the pain by giving a celiac block. So this is in the stomach, like just below G junction. So this anechoic structure, what you see with the flow, is the aorta, and the first branch is a celiac artery. This hypoechoic structure is the ganglia. So we can inject directly into the ganglia or around the. If you are not able to identify the ganglia, you can inject at the root of celiac artery. This will help in reducing the pain. What we inject is triamcinolone and bupivacaine, and for neurolysis we can use absolute alcohol. Third stage will be EUS facilitates ERCPs. So in this, EUS allows to perform otherwise impossible ERCPs in patient with failed cannulation, or if the papillary area is out of reach, so maybe because of secondary to any surgery like post GJ or any Roux-en-Y gastric bypass. So difficult cannulation, EUS guided biliary rendezvous technique in this. So what we are going to do is, with EUS, we are going to puncture the CBD and pass a guide wire into the duodenum, and afterwards, subsequently, this will be we are going to catch with a side wing scope using a forceps, and we are going to complete the ERCP. So the technical success is around 70 to 100%. Adverse events is around 15%. So this is the steps what we are going to follow. From the duodenal bulb, what we are going to see, the first anechoic structure is a CBD. Second will be portal vein. So we are going to puncture the CBD with a needle. So this is the like puncture. So we are going to put a contrast to confirm the bile duct, and followed by passage of guide wire. So here we are going to pass a guide wire down into the duodenum, and this will be coupled with a snare or a body forceps, and we are going to complete the ERCP. So by this you can achieve the cannulation. If in the patient with surgically altered anatomy, so post Ruben gastric bypass or any post GJ, so we can what we can do is US guided transgastric ERCP in Ruben bypass. So there was a study which was compared this US guided transgastric by ERCP, that is EDGE, versus laparoscopic assisted ERCP. They found no significant difference in terms of technical success, but the stay and the procedure time was much lesser in EDGE procedure. So this is a technique what we are going to do in the Roux by gastric bypass. So we are going to bridge the gastric pouch with the excluded stomach with the lamps, and then we are going to pass the sidewind scope through the lamps into the duodenum and going to perform the ERCP. This is edge procedure. So this is a short video showing the same thing. So this is the from the gastric conduit. We are going to puncture into the excluded stomach. This is a needle. So you're going to puncture the and distend the stomach with contrast. So by interesting like by putting the contrast with so inflate as well and confirm the stomach. Once this is done, we are going to put a guide wire into the stomach, and then this is a guide wire. Then the system, or we can directly use autopsies where we can directly puncture into the distal excluded stomach. So open the lamps. This is the distal flange. And followed by release of the proximal flange. So this is lamps which are placed from the proximal and into the distal excluded stomach. Once this is done, this stent is done. And then the sidewing scope, duodenal scope will be introduced through this into the stomach and perform the ERCP as like before. This is dilatation which is happening. Done. Once it dilated, so enter into the distal excluded stomach, and then there's an ampulla. We can do cannulation and then perform ERCP. Oh, this is the ERCP. Once this is done, we can remove remove that lamps and suture the defect. So the fourth will be EUS replacing ERCPs. So EUS in these patients, ERCP cannot be performed and EUS directly, ERCP cannot be performed and EUS directly replaces ERCP. So for transmural biliary or pancreatic drainage. So for example, EUS guided hepaticogastrostomy, EUS guided choroidochoduodenostomy, so EUS guided pancreaticogastrostomy. So to there was a systematic review to assess the efficacy and safety of EUS guided biliary drainage. In this meta-analysis, so EUS guided transmural biliary drainage can be achieved in around 95% of the patients, and the clinical success for around 90%, adverse events for around 24%. So there was another study which showed EUS guided choroidochoduodenostomy versus percutaneous drainage. So in this study, the 13 patients were treated with US guided choroidochoduodenostomy versus PTBD around 12 patients. So they showed significant difference. They did not show any significant difference in terms of technical success or any clinical success are also same. Adverse events are also same, not no significant difference. This was a recent study which showed US guided choledochoduodenostomy versus PTBD. So in this also there is no significant difference when both this showed like when both the PTBD and US guided are available, both techniques are available and feasible. US guided choledochoduodenostomy is always favorable. So this is choledochoduodenostomy. So we are going to enter the duodenum. This is the first part of duodenum with a echo endoscope. This mass in the head region, a complete cutoff of the bile duct. This duct. So in the color Doppler, there is no flow. This is an anechoic structure, dilated. So we can use two methods. One, we can use so this is autopsies where we are directly puncture into the bile duct, confirm it by putting contrast. So you can see a dilated CBD with abrupt cutoff. So place a guide wire. Then either we can use lumen approaching metal stent where you can use it directly. So this is a stent which is coming. Puncture CD. Yeah. Then deploy the distal flange. This is a distal flange. Followed by deployment of the proximal flange. So this is a proximal flange in the duodenum. So other thing is EUS guided hepaticogastrostomy in a patient with where we can't do ERCP, we can go ahead with the hepaticogastrostomy. Same in this technique. So from the stomach, we are going to the left hepatic duct. So this is the left of the liver, and this So aspirate and there's a bile duct. Then put a contrast. So it will dilate the duct and also give the biliary anatomy. So apply contrast. Then place a guide wire, and this is followed by the placement of luminescent. So this is a metal stent. So conclusion. So US ESCP interface has transformed the management of biliary pancreatic diseases, and it requires high level and dual expertise in both US and ERCP. Integration improves diagnostic accuracy and also therapeutic efficiency and also patient safety. Thank you.
So after the how to follow
Correct.
any precautions before this.
So after proceed, how to follow. So for ERCP, like US followed by ERCP if suspected CBD stone. So once you are achieved a clearance, so maybe you can repeat an ER ultrasound just to confirm if there is any residual stones or not, and then you can remove the CBD stent. If for any US credit procedures like or US credit bilirio like corticosterotomy or pancreatic biliary drainage, maybe after we can keep a stent for at least 2 3 weeks and then we can remove so that we can achieve a patency. So what are the expected risks like bleeding? So if for ERCP, so bleeding risk is around maybe 1 to 3%. Pancreatitis also it is around 1 to 3%. Common sense of complications of ERCP. Bleeding, you can see once you are doing a splenectomy. Sometimes they may have a delayed bleeding after maybe a couple of days also. They will have melena or maybe present with frank epidermis. Pancreatitis day two once like when the guide wire has gone into PD for multiple times or you injected contrast which has gone into PD. So there may be chance of pancreatitis in the second day or maybe the after 6 to 8 hours patient will have severe pain, so that we can manage conservatively as acute pancreatitis. Any other questions? Thank you.
Okay. Anapantaman. Narrating. Off பண்ணிட்டுங்களா? Okay. Good evening, one and all. Can you all hear me?
Sir, I can hear you, sir.
We can hear. Okay, fine. I'm going to the presentation.
Fine, sir.
Uh, you can see my slides, please. Sorry for delay.
Yes, sir. Yes, sir.
Uh,
Yes, sir.
Very good evening to one and all present here. Sorry for the delay. Was held up in a emergency endoscopy bleeding. Pancreatic endoscopy is the topic for today, and this is a very important update in the HPB space, hepatobiliary space, when it comes to the therapeutic endoscopy. I am Dr. C.G. Sridhar. I am a medical gastroenterologist from GEM Hospitals, Coimbatore. I thank Team Televersity for giving us the opportunity for sharing our work with you. I sincerely thank Parsari sir, Venkatachalam sir, and Pasupati brother for organizing and conducting this flawlessly. Thank you so much. When it comes to let's go to philosophies of pancreatitis and where endoscopy plays a huge role. One of the very commonly encountered area is recurrent acute pancreatitis, and endoscopy plays a huge role in this space because the role of EUS is a very important area in this picture, where in the diagnostic front, where MRCPs and MRI only plays a supplementary role and CTs often miss microliths and occult malignancies. The role of EUS is tremendous. The image you see, the small calculi you see in the image in the left, and the microcalculi in the gallbladder, which you see in the image in the right, are only feasible with a tool like endoscopic ultrasound, which is the closest range you can get to the target organs concerned. And sometimes occult malignancies, which are very difficult to find out in pancreas, can be picked up in EUS with a good sensitivity. The second topic of common dilemma is pancreatic divisum. We often get a referral saying we need ERCP for pancreatic divisum, but is it really necessary? We need to consider a pancreatic divisum endoscopy only in a dilated duct. There is no role of PD stenting for every case of pancreatic divisum just for pain relief. An acute pancreatitis need to be treated like an acute pancreatitis irrespective of the cause, and pancreatic stenting is not going to improve the outcome of the patient in an acute setting. Once the inflammation subsides and we have a clear cut idea of the ductal obstruction with a dilated dorsal duct, then we have a clear role in pancreatic divisum to do either a biliary sphincterotomy, dilatation, or stenting is relative depending on the outcome of the patient, but we need an undilated dorsal duct is no role to play in a PD stenting in a setting of pancreatism and never intervene in an acute setting. This is a common flowchart which we have to see when it comes to an acute necrotizing pancreatitis, which is accessible endoscopically. The ball goes into two fronts in the name of plastic stents and lamps, only with the amount of necrosis. If it is a clear fluid, which is small size and predominantly liquefied, less than 30% is only liquid, and it is very close and accessible to the lesser sac or accessible to the posterior wall of the stomach, then a double pigtail plastic stent, single or double, or even a nasobiliary drain placed within the cavity works very well as a transmural drainage in acute pancreatitis, provided it is more than 4 weeks, provided the wall is well formed, and if it is not well formed and it is too early also, only intervene in the case of sepsis or when the patient requires a drainage. Never consider the lamps placement and plastic stent placement very early on unless indicated. The lamps can be considered, which is a lumen opposing metal stent, which can be placed transgastrically only when the lesion is significantly large with clear walls and more than 30% of debris is present within the necrotic collection. And lamps can be considered. The lamps can also be used for critically ill, clear liquefied cysts when they are critically ill and you need rapid decompression of the septic material in the case of cholangitis. There are two ways again the whole necrosis can go. When the amount of necrosis is less, you don't need to go in with multiple sittings of re-entry in through the tract into the necrotic collection to take out the debris. If it's a clear fluid, there is no other re-intervention. The one sitting procedure, the whole thing is done. But whenever there is amount of debris is large, you will need to go enter in again, use hydrogen peroxide to do enhance the necrosis debridement, and powered endoscopic necrosectomy devices are also available. But in a resource limited setting, we often use simple devices like blunt dissection with the closed polypectomy snares, and then removal of the debris with the snare, and even sometimes baskets can be used to remove the debris serially sequentially through the transgastric drain. And always have a multi-gate approach with the percutaneous approach hybrid along with your endoscopic approach, in which better clearance can be achieved. Sometimes you can use a nasobiliary drainage, nasocystic drainage to facilitate even flushing, and you can enter into through the other gate to do the necrosectomy. So multiple options can be done depending on the case to case basis, but these are all much more important. When the collection is resolved, the lamps can be removed before 20 days or on day 20. Never delay a lamps removal because the risk of bleeding is pretty high when you remove late because of the neovascularization and the vessels formation, and even sometimes the necrotic material can get stuck inside the lamps and causes much more deleterious effect. Whenever removal of stents is considered, always consider whether the patient has got a disconnected pancreatic duct or a disconnected pancreatic duct is absent. Whenever you find no pancreatic duct disruption, you can happily remove the stent. If you consider pancreatic ductal disconnection, always make sure you leave one or two stents through the same gate indefinitely period so that the collection is retained. If the if you even consider the lamps being placed earlier, you replace it with a plastic stent so that the drainage is maintained and the whole sequence is cleared over the time. And this acts as a bypass route through which the pancreatic juice and the disconnected duct can flow into the stomach. Another very important area where we find endoscopy to be very useful is chronic pancreatitis. But we need to understand the surgical approach is the mainstay when it comes to the chronic pancreatitis management, especially with a fibrotic disease like chronic pancreatitis. And surgical intervention is the mainstay in case of chronic pancreatitis with the obstructed main PD. Only when contraindication is there to surgery, we need to consider or offer a less invasive modality like endoscopy. And patients with painful PD who are not willing for surgery and who have a very dominant PD stricture can still consider to go for a pancreatic stent placement as an initial treatment. And the main intention to tell the patient is it won't be a single sitting procedure, it needs to be a multi-sitting procedure, and we need to place more than 1 to 2 stents or serial stents to upgrade so that the lesion, the stricture gets dilated and the ductal obstruction is improved. The role of ESWL we'll discuss sequentially. When it comes to the question of use of metallic stents, the studies are against the recommendation of using the fully covered metal stents in the PD strictures due to the even despite the failed initial procedures, the studies is very against the usage of fully covered metal stents. And another important thing is the ASGE guidelines, which is the American Society of Gastrointestinal Endoscopy, suggests The management strategy has to be having three most important ideas: the stone size, the location of the stones, and the radio opacity of the stones. The radio opaque stones, which are more than 5 mm in the head and the neck and the body, we ASGE still suggests ERCP with or without pancreatoscopy or ESWL alone. Whenever the radiopaque stones are less than 5 mm or radiolucent stones or patient with contraindication to ESWL, ASGE suggests ERCP alone with or without pancreatoscopy where a PD stent can be placed directly. For post ESWL, when there is no spontaneous clearance after adequate fragmentation, we can still consider ERCP with or without pancreatoscopy for stone clearance. So it's simple. When it's less than 5 mm, you can go ahead directly for a pancreatic duct stenting and an ERCP, and ductal clearance can be attempted. For more than 5 mm, which is radio opaque, we will need with or without pancreatoscopy. It's a spyglass which we use, and the same spyglass can be used inside the pancreatic duct, and we can use a electrohydraulic lithotripter EHL can be used, or even a holmium laser can be used to break the stones. When the institution has a device like ESWL, you can go ahead for an ESWL directly, and then when the fragments are not adequately cleared, you can proceed on to do an ERCP later for ductal clearance and for the stenting. This has to be the sequence for the CCP patients. Let us see some videos of the patient in which the fully covered metal stent has played a big role in a chronic pancreatitis or even a pancreatic head mass causing a distal CBD obstruction. In these cases, when it comes to the biliary strictures, either benign or malignant, the scientific literature for a fully covered stent or a biliary metal stent has a higher implication rather than plastic stents, which requires multiple sittings. And one important thing is we have to rule out a malignancy in these settings. And without ruling out a malignancy through a brush cytology or a EUSFNA, don't rush in to place any stents because the whole image gets disturbed. And always have a clear lookout for benign biliary strictures in any case of CCP, and try to avoid multiple sittings of ERCP with a single sitting of fully covered metal stents, which can be preferred over multiple sequential plastic stents for benign biliary strictures. Malignancy, once proved, it's very clear. If it's operable, we go for surgery. If it's inoperable, then you consider for the metal stents, and you can proceed towards the chemotherapy and everything. Uh, the videos I'll play it in the end. I'll try to play. Not able to get this. Okay. When it comes to chronic pancreatitis and pseudocyst management, we have a number of tools in the form of EUS, in the form of surgery, we have the form of ERCPs and percutaneous drains and everything. But we need to always have a measured approach in the case of a chronic pancreatitis or acute pancreatitis with complications. And the mix and match and the serial tailoring has to be made according to the patient's basis and needs. These are images. Let me share it in the other sides. This I'll show it in the other presentation. Apologies for this. Kindly hold on. Sorry, due to technical difficulty, I'm not able to show the videos as intended. This is an image where we had a patient with a distal CBD obstruction, which was palliated with a fully covered metal stent. This is a video of a necrosectomy video where we did endoscopic necrosectomy in a patient with acute pancreatitis. Uh, for the want of time and the delay in presentation, I'll close the presentation with this on this note. I re-emphasize pancreatic endoscopy is not about winning or losing. It is about saving patients, and surgery has a huge role in saving patients, as endoscopy does. And endoscopy, being a much more less invasive procedure, can be considered safely on case-to-case basis at the appropriate time, at the appropriate lesion, and with the appropriate tools. Thank you for patient listening. I'm still not able to open that PowerPoint. There's some issue with that. Pasupati brother, any questions?
Sir, a question in chat la போட்டுருங்க sir. What's your preferred stents in PD ன்னு கேட்டிருக்காங்க.
We often use plastic stents, sir. Whoever asked a question, we for pancreatic stents is always a single pigtail 7 French plastic stents. And we serially progress with other. If there is very tight, we consider 5 French stents with a single pigtail, and depending on the length of the thing. Patient who does not fit for this procedure. Basically, see, my point is always offer surgery first. It is always like patients who are not fit for surgery, you should tell me. CCP with, what do you say? With the dominant stricture, you can always consider ERCP as a first role of choice. In settings like, always consider malignancy before putting in a stent in any of these patients. Be it pancreatic strictures or biliary strictures, always rule out malignancy with the breast cytology. That will be the first thing. And IgG4 is another disease where you need to consider more. Expected complications are stent migration first, bleeding is second. Then, like how we have sepsis within the CBD, we can have obstructed sepsis within the PD. Pancreatitis itself can get aggravated by PD interventions. These are the routine complications of any procedure. Then pancreatic sphincterotomy bleeds. All those things are as routine as any ERCP. I can see somebody typing questions. Bleeding during a procedure, how to tackle? Routine. The sphincterotomy bleeds, we can use electrocauteries which are monopolar, and we can even use sclerotherapy to use adrenal injections. The procedures can be even managed with clips. Refractory bleeds, we can still consider to go ahead with fully covered stents if bleeding is very profuse. Intervention radiology needs to be considered only when the whole disease process is much more deleterious, and where intervention radiology procedure is required, where an inadvertent pseudoaneurysm is bled, and things like that. This having open, I'll just try to open this, sir, if at all possible. Any questions? Meanwhile, I'll take it.
So, post of infections and precautions ன்னு கேட்டிருக்காங்க.
Post-op infection. See, what we do right here is every patient doesn't require a prophylactic antibiotic. Unless it's an infected system, you need to consider. We use piperacillin tazobactam, which has a very good tissue penetration, and helps the patient in this patient when it comes to the infected collections, and always ask it collection in a cystic collection, and always send it according to the sensitivity. You can always proceed for the antibiotic of choice. Pain management is always hydration, rectal suppositories of indomethacin or diclofenac can always be considered. The routine ERCP and procedural instructions. Anything in specific we could discuss. No role of octreotide. Nutrition is another important area. If you have a patient who has been malnourished, please consider nasojejunal feeds in chronic pancreatitis or acute pancreatitis who is not feeding well. If they're tolerating well, encourage oral feeds. TPN should be the last resort. How long will be the hospital stay? Depends, doctor. Whoever asked the question, it depends. Totally depends on uh, how long the. It all depends on the control. If it's a single sitting procedure with just a liquefied cystic collection, it just empties and they can go home the same day or the next day. If it's an infected collection with a lot of debris, you'll require repeated settings of re-interventions, which might take weeks for the hospital to stay. It all depends on case to case. Every other video is opening except for the pancreatic necrosis. Sorry about that. Anybody can see this video?
Yes, sir.
What you can see is the endoscopy entering into the cystic with lot of pus and necrotic material. And this is endoscopic necrosectomy where we put in the snares to remove the debris and sequentially do the necrosectomy inside the pancreatic necrotic collection. We are using simple snares and we need to jiggle the snare a bit and make sure it's a free debris and we're not catching on to any vessel or any vascular structure there, and make sure blunt dissection of the using the endoscope, the polyp tip helps in mobilizing the debris and catching the unnecessary vital structures. So the debris is the target. So we always try to jiggle the polyp snare a bit before just dragging the scope with the necrosector. It's always adherent to many of the things. So we jiggle like how you see the front and back. You can see a bit of movement and give way. So that is a sign where it's a debris which is the hold, and you can see how beautifully it's coming out through the cavity. It needs to be a slow, steady process. See, unlike laparoscopy, we don't have triangulation to catch hold of one with one instrument having multiple ports and everything. The luxury remains with the single axis, single port. Even with the therapeutic scope, the axis remains the same. So, this is a slow, labor intensive process, but it's always worthwhile, and I'm sure there'll be much more tools in the future to facilitate this debridement. We already have mechanical debriders and electrical debriders to enhance this. It's like a morcellator where this whole debris can be the whole necrosectomy and that debris removal can be done in a very fast paced fashion. You can actually see more as and when the procedure is being done, the cavity is getting cleaner, and more cleaner. You can see the depths of the cavity going up to the thing, and you can see the pigtail there actually. If you see very watch once this debris is removed, you can see the left flank pigtail. You can see once this debris is removed. Hmm. So that is the depths at which even the paracolic gutters can be reached through the same thing. There you can see the pigtail here. Yeah. So that is a left paracolic pigtail which has been put using ultrasound, and it gives a very good satisfaction even for the therapeutic endoscopist. So, so when it comes to the check endoscopy later on, you can clearly see uh, the lamps has been removed in this patient. The cavity is still persistent, and you can enter into the cavity and you can see the beautiful cavity without much of the debris there, and only healthy granulation tissue with a bit of blood. It shows the it's a clean area and the whole necrotic cavity is being cleared. This patient had a STROMI course with who required a lot of effort back then when I was working in Chennai. But it's a very memorable case that he's doing very well and he settled abroad in Kuwait. So thank you all for listening, and any more questions? When will you send to a patient to have HPV surgeon? It's never about sending a patient. Always keep the patient. You can always need surgeon to come on board. Surgeon and the physician goes hand in hand. You cannot chop off your right hand for work and left hand for your home. So gastroenterology is a single specialty where surgeons and physician have to go travel hand in hand, and pancreas is one area where you have to travel hand in hand. There's nothing, even when you send a patient to a surgeon, when there is a disconnected pancreatic duct, the collection will reappear if they just do a single setting procedure where a cyst is decompressed with the gastrostomy or cystogegnostomy. There is a chronic pancreatitis. You always need to have a continued medical care, and you sometimes will require